Rett syndrome, identified only as recently as 1966 by Dr. Andreas Rett in his clinic in Vienna. Rett syndrome, then largely unnoticed until 1983 when it was rediscovered by Professor Hagberg in Sweden. This film is the first attempt on film or video to show some of the consistent, recognizable symptoms of the disease, to watch therapies being tried in treatment, to listen to the experiences of two families with a Rett syndrome girl, and to gather expert medical opinions.
Look, I will finish with a sentence produced by Katie Hunter. Katie Hunter is the president of the United States Association. She said, care today, cure tomorrow. And it's true. Now we must care this child. We have not a special treatment. And we must care. We must care in any dimension of her life. It's possible that we find the reason. It's possible that we find a treatment, a special treatment, cure tomorrow.
Let's care today and cure tomorrow.
The pioneer work of Dr. Rett and Professor Hagberg and others throughout the world is now coming into focus. The syndrome, found only in girls, is probably commoner than 1 in 12,000 female births. What are the principal consistent symptoms? Loss of purposeful hand usage, the development of repetitive hand movements, ringing, patting, tapping, mouthing. Grinding of the teeth, holding the breath, swallowing air, grimacing of the face. Loss of brain control, wasting of the muscles, and poor circulation of the lower limbs can produce an unsteady, wide-based, stiff-legged gait. Regression in social development, sometimes but wrongly confused with autism. Abilities in toilet training, dressing, feeding, all these skills can disappear in the girl.
What the eyes of these children says, they cannot show us, but behind the eyes are much more than we believe. All the life of these children is concentrated in the eyes.
Come on, put your hands down. A big girl, come on. There's a big girl. What can you see? What can you see? See the light? There's not a light there.
But I mean that all what these children feels and what these children like to say, it's in the eyes. All is concentrated in the eyes. And everybody has wonderful eyes. Wonderful eyes. They have no movements in the mimic muscles, but the eyes are speaking to us. And if you are, as a physician, if you are able to explain the child, if you bring nearer, if you explain that in this brain something is doing, that the children can see everybody, that the children can know who comes into the door, that they can smile, then they react. This is important, to bring nearer the child to the parents.
Curvature of the spine, scoliosis, can occur in some girls. Spinal deformity can develop slowly, and parents concerned about this feature should seek early clinical help. Even with good bracing and regular physiotherapy, a progressive deformity can develop. Surgical treatment to stabilize the spine has been successful, but the operation is a major one.
Come on then. Good girl. Good girl. Come on.
I think, first of all, it's necessary that the physicians learn this sickness. If a physician has seen one case, he can make all the diagnosis. It's no problem. It's no problem.
When I began to study it was thought that the child was normal before the regression occurred. And it became very clear, talking to parents, looking at very early film taken, that this was not so. That although the child seems normal, there are minor deviations from normality very early, from 4 or 6 months. There's a stagnation in skill. There's an inability of the child to cross a certain milestone barrier into mature use of the hands, into mature speech use, sentences and so on. And this is a very interesting developmental phenomenon. And then at regression, which is very characteristic of Rett syndrome, the loss of skills, the loss of speech, the loss of hand use, and very often loss of ability to walk, the disease becomes apparent. And yet we know it's been there all along, so we're getting a curious step down in skill level, although we know that this is a child who must have had the disorder from early.
And to this time, it's going very well. And this is the point, because the parents doesn't believe that her girl is sick, because all was normal. No disturbance. Not disturbance in the family, not the same sickness in the family. That's the point. If a child came to birth and seems as Mongolismus, everybody has the diagnosis. But in these cases, the problem is this distance between birth and between the first symptoms.
The regression stops after sometimes just weeks, sometimes years. And then the child is on a level. There is progression of the physical disorder, so there are thin legs, cold feet, tightness of muscle, a tone disorder, a scoliosis. But these, I think, are the sequel of the original abnormality which was there at birth. Mentally, the child who's finished regressing is stable. We see people of 40 years old who are just as bright as they were at 5.
And call the dog.
Yes.
She used to call the dog.
Yes. Ben? Ben? That's what you used to say. Yes, she used to have quite a lot of words too, didn't she? You used to say balloon. What other words did she say? Dad. Oh, she always said dad, didn't she? She always said dad, didn't she? Never mum, always dad. Yes, yes. And then all of a sudden, she started to stop doing those things, didn't she?
She stopped looking at the books, and she stopped actually looking at the pages and turning the pages and feeling the pages.
Yes.
And all those sort of things slowly disappeared.
Yes, she stopped looking at everything, didn't she?
Her eye contact went completely.
Yes.
She stopped looking at you and me and the dog, and she'd look the other way.
Yes. But by this time, Claire was very different, wasn't she? You weren't the same little girl that we'd had at all, were you?
She started banging her head then, didn't she? She'd go into a corner and start banging her head.
Rocking on her knees and banging your head against the wall and crying and crying and crying. We couldn't stop you, could we? Just went on and on and on, and we couldn't see what was wrong. Couldn't see what was wrong at all. Everything we tried, nothing worked. Everything we tried to stop you crying, nothing worked at all, did it?
I think then she just stopped feeding herself as well. She'd been finger feeding and that had stopped. And she'd sort of given up on that, and we were feeding her, back to feeding her again.
Yes, we couldn't believe it, could we? We kept saying, children don't go backwards. They don't, but they did. You did, didn't you? And then you started doing those funny things with your hands, didn't you? Yes, and we tried to stop you. Tried everything we could to stop you.
It started with that rubbing movement here.
Yes.
And that was all, and then it started to develop into a tap.
Yes.
Then it slowly came up to her mouth.
Yes.
And then her other hand started doing that sort of thing.
Yes, and we kept trying to stop her doing it because we thought, oh, it's a habit. She'll grow out of it. It's a habit. And we tried all the different things we could to stop her doing it.
They made that splint at the hospital.
Yes.
Somebody got us a splint made.
Yes.
To keep her arm
stiff. Just kept her arm really, really stiff.
And even that didn't stop you, did it?
No.
Hey? You bent that eventually.
Yes, and we tried. I tried painting that stuff on her nails. Somebody suggested to do that.
Horrible.
Yes, I thought you didn't think much of that, but she still kept on doing it, didn't she?
Yeah.
She just, even though it was horrible taste, it was awful, wasn't it? Yes, and she still.
Feed it down there then. Jane appeared normal until she was 2, and then she began very high-pitched screaming, didn't appear to be making any further progress, although by that time she was walking, riding a bike, playing with her dolls, generally perfectly normal. She went to the autistic school, they couldn't cope with her there. She was becoming increasingly violent, both to herself and to her sister. At the age of 7, she was at a local special school. She really became more and more aggressive. She never slept. She was headbanging, biting herself terribly and her sister. They used to have to wrap up all the edges of the desks, the doors and everything. And in the end they said they just couldn't cope with her anymore. We'd have to have her admitted into the local hospital. This of course wasn't very easy. No one knew really what to do with her. But in the end it was decided that for her own safety and for that of Louise, she would have to go full-time into the local unit for severely mentally handicapped children.
We must accept that at this time certain therapies are experimental, efforts by devoted professionals using endless patience to try proven techniques on the Rett girl. As yet, no drugs have been found to improve the condition of the Rett girl. If epilepsy has occurred, however, then control can usually be achieved with the usual anti-epileptic drugs. Here, the hands and skills of the physiotherapist are seeking to relax the muscles, to prevent, or at least to slow down, the stiffening of the joints.
Will it come a little bit more? A little bit more? Great. Good girl. Good girl. Good girl. Let your head rest there.
The girl may have learned to walk, and then may have lost the skill. Exercises can be developed in the special school, and then with parents in the home, to maintain and even strengthen such skills as do remain.
Good girl. Good girl. Clever girl.
On your hands. That's it. Come on.
Virtually every Rett child can stand and many can walk with a varied degree of support, so every opportunity must be taken to encourage active movement.
Put your pushchair up.
Yes.
Yeah. Dad, lift you.
Keep them out now. You look at them. Look at this little hand. Look at it. Look at this little hand here. Look. Look at it. Look at it.
Here, the physiotherapist is encouraging the natural outstretching of the arms. The child is gently guided to stretch the arms and the fingers.
Look at them.
This looks a bit precarious, but the use and positioning of the hands is used to encourage the child's ability to balance.
Put your hand on the door. Good girl, that's lovely. What about some little fingers there? Right. Let's have those long fingers, Sarah. And again, long fingers, Sarah. Good girl.
A pocket full of roses, a tissue, we all fall down.
This is the well-proven joy of warm water, the comfort and the sensory pleasure, the togetherness of the group, the girls and the parents. The girls can experience the upright position with some confidence. The buoyancy of the water gives freer movement and maintains mobility of all the joints, including the spine. Underwater jet massage and air baths have recently been developed.
Oh, it's come out again. Can you see the water? Can you see the water, Claire? Good girl. Keep going. Come on, this is going to be fun. Good girl. That's right.
Again, the skills and the techniques of the professional can be followed by the parents in the special pool or at home.
That's a better girl now. That's lovely. What a nice smile. Yeah. Do you want to try that with her? Yes. Try and find her toes and then... I need to put the head on my shoulder because if you lift a bottom, it's just under her bottom, under her pelvis, and crouch down yourself so you're really low. You can just swing, swing, swing. her head relaxing.
Now this is possibly one of the most experimental of the therapies, music therapy, endlessly seeking for a communication with the child, some positive reaction that understanding could be taking place.
Our clinic was the first clinic. They treated handicapped children with music therapy, and this is a special reason. Musicality and feeling for rhythms and for melodies, also the mentally retarded child has this feeling, because the center of this feeling is in the brain, is in a area which is never destroyed. And most of the severest retarded children have not a way out, have not a way to show his... No outlet. Only with music.
Pauline can play. Pauline.
It's a way to the girl, and it's a way out from the girl to us to get a reaction. That we find that a special music therapy, it's very difficult to do this treatment, but it's a reaction. And this is very important, that we find some reactions.
Pauline can play the cymbal.
For children who don't have language, to be able to communicate on a broader level with musical sound is very important, and you see the importance in the child because there's immediate rapport, excitement, desire to communicate, which becomes evident when the therapist begins to work. Gradually, and it's week by week over a long period, you get a communication through the music. So you're in fact producing a kind of duet. The child puts in a bit, the therapist ornaments it, builds it into something, feeds it back, waits for the child, and the child understands this. And you see a delightful relationship grow, which means a great deal. The child has discovered that she has some power, she can communicate, she can take part.
Bye-bye.
Listen, Claire.
Nowhere is the patience and care of teacher and of parent more challenged than in effort at educating the Rett child, so that simple words, simple expressions might be understood. It will be slow at first, but greater gains have been achieved when the regression stage is past. So repetition of the exercises by the teacher and by the parents is essential to stimulate as much as possible the disabled mind and body.
This one. Good girl, you are clever. That's your name, isn't it? That one says Claire. Open your eyes. Do you want to play with your elephant, Claire? Do you want to play with your elephant? Yes or no? Quickly. No? Come on, yes or no?
Okay.
No, thank you. You don't want to play with your elephant. Would you like to play your... Yes! Look at yes then. Show me yes, if you'd like to play it again. Good girl, Claire, you are clever.
Right, should we play with your cassette, Claire? What have we got here? Dance Mix 87. Let's put this in, shall we?
Think of those exercises of the physiotherapist,
Now then,
opening and stretching those long fingers. The positive reaction of the child to flashing lights, to sound, to rhythms and tunes, can be linked as here to simple cassette players and starting pads. The child must make a positive action to get the pleasure she expects.
Make it play. Come on, you make it play, Claire. See it? Your friends like this in school, don't they? Keep your hands out.
good one, isn't it?
Many specialised computer programs are available, which again encourage hand activity, where the child must stretch and touch to activate the game and to get the anticipated pleasure and fun. Some of these games and units can be expensive, so remember the toy libraries for the handicapped. Borrow them for a trial with your child in your home.
There's a garden. Press again. Press again. Good girl. There's the house. Right. There's the roof. Red roof on it. Good girl. There's your house. What are you going to put on next? Put a roof on. There's the roof. Good. And a door. And a window. Press that. Good girl. There's a tune. There's a tune. That's the ball in the house. There's a tune. There. Do that again. Do that again.
Oh, lovely, thanks.
Yeah, I'll put it.
Right, thank you.
Come on.
This special handicapped child swing gives Claire endless fun and security out in the open air of the garden. Other swings are available or can be adjusted to allow the child's feet to touch the ground and give self-propulsion, swinging, moving from side to side, all in perfect safety.
Is that nice? Is that nice? In the sun?
All girls with Rett syndrome are totally dependent upon parents and carers for all their needs. As with the therapies, with toileting, dressing and feeding, endless patience and time are required. And so much time is involved, care will need to be shared within and outside the family.
Want a drink?
Feeding is a vital, regular activity. The majority of girls enjoy the food, but there may be problems coping with the difficulties in chewing and swallowing.
Come on, chew it. Ready? Finish your huffing puffing first, that's it.
We're a thirsty girl.
In special schools and adult training centres, with chairs that give strong support for the spine and keep legs and arms under control, work will always continue to find ways of encouraging or regaining the lost skill of self-feeding, holding the spoon and searching for the food on the plate.
Silly, wasn't it? Now hold your spoon. Oh dear, it's got bones in it. Hold your spoon. Good girl, you're looking nicely, aren't you? Come on, it's pudding. Come on. Oh, just like you try you. Try again. But it seemed that after when she got to about 12 and a half, she reached puberty. She decided one day she'd walk again, got up and walked, and gradually, since then, she has calmed down. She's on very little medication, if any. She'd had the odd epileptic fit, but now she's become, as she appears now, happy. She still has tantrums and gets very upset, but very, very few and far between now. She just needs total 24-hour care. She can't do anything for herself. She's no toilet training, can't feed herself, but generally just sits curled up lots of the time in the fetal position and is just very content to do nothing. I do feel that all the Rett parents are going to have to face the problem that we have faced. The children eventually are going to have to go and be looked after permanently. We can't have them with us forever. They are very, very draining. It's just really a case that we have got to find somewhere for the Rett girls to live. If we could only get a purpose-built home where they could live together, if only just for the holidays to give their parents a break as a start, in my mind, this is where the Rett Society has got to move.
I started the association early in 1985. We have a child with Rett syndrome. As she was one of the first children in the country to be diagnosed, we know what it's like to feel isolated and alone. I was determined that the creation of the association would put an end to that for new families. For the first 6 months, I ran the association on my own. It started in a very small way, but at our first big meeting, attended by Professor Rett himself, I was able to recruit a secretary and treasurer and others keen to work for the association. The team has worked hard and well together. In 3 years, we have developed a large and still growing national organisation, which is a registered charity. We now have over 200 families with a Rett syndrome girl known to us in the UK and many overseas too. We offer the families and carers of all Rett syndrome sufferers, both children and adults, support, friendship and practical help. We work with doctors, consultants and other professionals, helping with research projects and other important work to improve the quality of life of all those with Rett syndrome. Pam, every parent wants to obtain the best sort of equipment for their child, whether it be pushchair, seating, both for school and in the home. How would a parent go about finding the best sort of equipment?
The particular features on this that are good are that you've got this firm supportive back, and it cradles the child round here so that they can't fall either to one side or the other, so that they're snugly fitting into it. There's also space here for a pummel, which is basically a padded post which slots in here and stops the child's pelvis sliding right forward, so you get a good pelvic fit here. And it's got nice adjustable footrest here, so you can get that to the right height. Now that's those features are something that you would look for on any chair, and this chair also has adjustable footrests.
We give information and advice, not only to parents and carers, but to professionals too. We produce a regular newsletter to keep members up to date, and we hold an annual conference together.
The majority of parents coming know a lot about the disorder. They've come to terms with the situation in their child to some extent. So they themselves are very supportive of the new parents coming in who've just discovered, who are shattered to find how handicapped the child is, that there's no magic cure, that life is long and they have a heavy burden. So meeting of parents is very valuable. It's very valuable for doctors to be able to see children with the disorder. And each time we've had such a meeting, I've met doctors who've come away saying, this is a mind-blowing experience. You know, they've read the books, they've read the papers, but to see the children and to realise how like they are to one another, how very interesting, and how different from the literature. So it's good for them to meet parents and to realise how much parents have to give them, what good colleagues parents are.
You must know that most of them patients are not diagnosed, and it's terrible for parents not to know what her child has. And in the United States 3 years ago, I heard the first time the sentence, "Now we are not alone." And this is so important. Now we are not alone. Now I know what happens with my child. And I know also other parents with the same problems, with the same troubles, with the same thinking during the night. This is the point.
Our workers at the local level are a whole network of regional contact parents, promoting the association, giving information and also fundraising for us. As the association grows, more new members are coming forward to join in the work of the association. Now looking to the future, our priority areas are publicity, to tell the general public and all in the medical and educational fields about Rett syndrome; fundraising to support research projects and cover the association's running costs; and finally, to meet the very specific needs of our girls, work on the establishment of short and long-term relief care facility for all with Rett syndrome.